Hi everyone, welcome back to the Old School RN. Some news that's happening in this world of nursing, world of NHS. I've got that much of it. I'm going to have to do it in different videos because there's just so much to talk about. Okay, first of all, when you're a registered nurse or a nursing associate, you have to be registered with a body called the Nursing and Midwifery Council. And when you go on there, you can put in the name of a nurse or associate and it will come up with their registration, that they're compliant, that they're fit to practice, etc, etc. Now this organisation is a devolved organisation, so it has certain powers to suspend nurses who are bad practice or have got in trouble with the law or who have been reported for poor standards, etc. And they can rule against taking your registration from you or imposing certain sanctions or extra training or whatever. Now, going back in time, when I started nursing, we had the General Nursing Council. There were three bodies. There was the General Nursing Council, there was the Midwifery Council and Midwifery Board, and the Health Visitors Education Council. They were all amalgamated into one and they became what was called the UKCC, the United Kingdom Central Council for Nursing, Midwifery and Health Visiting. That was disbanded, and then 2002 it evolved into the NMC, which is the Nursing and Midwifery Council. Now the aim, and it is an aim, it's not a law, it's an aim of the organisation is to uphold good professional practice within the nursing profession and nursing associate profession, and it's to safeguard the public. So the NMC is there as a sort of regulatory body. Now, like all these government devolved sort of organisations like the NHS England, etc., these organisations seem to be a bit of a power unto themselves. There's been no real auditing until fairly recently, at least in the last decade or so. And the latest report that has come out this week, literally this week, has now stated and condemned the NMC because they failed their inspection on 7 out of 18 very important points. Now, one of those is their culture. The NMC has been ruled to be a toxic bullying culture towards its staff and towards the nurses that are regulated. Now, any nurses who are reported to the NMC go through a really difficult, arduous and punitive, I'd say, process, sort of a guilty unless proven to be innocent kind of rule, which is stressful because while you're suspended as a nurse, I wouldn't know, it's never happened to me, thank goodness, but the nurses I've known who have been through this process are suspended and they are literally unable to work. They're not able to work as nurses. So it could be based on bullying allegations, you know, a group of nurses have mobbed and said, well, this person isn't fit to practice because, and they've been reported. It could be for something that was seen as a slur on the nursing profession, so bad reputation, etc, etc. It could be for, you know, the fact that you've been arrested but not charged for a crime. You will be suspended. You are not allowed to work as a registered nurse under various circumstances, those being a few of them. Now, by upholding standards for the public, it means that nurses are regulated, they keep up to date with their practice, that they are safe, that they are properly trained, and they are who they say they are. Now, there's been articles recently that have been kept in the dark, shall we say, from the media, whereby approximately 1,700 plus, there's probably more, there may be less, I don't know, nurses who were registered by the NMC, but who in fact were not registered nurses. They falsified their qualifications, they've given in photocopies, they were brought from overseas, or they've lied and said they were a registered nurse when they were not. Now, if you call yourself a registered nurse and you're not one, that title is protected by law, so you could receive a prison sentence for that. I think it was up to 6 months in jail if you pretend to be a registered nurse. So there are implications around this. It's not only keeping the public safe, it's about life and death. You know, there are people practicing and giving intravenous drugs who are not qualified to do so, who are not trained to do so. And I say this because there is a myth that's being peddled around that the employment status of a nurse equals the standards of a nurse. Totally untrue. An agency nurse, which is someone who is employed by an outside contractor but is under contract to work in a hospital, an agency nurse is just an employment term. It depends who you're paid by and what your employment structure and contract is. It's got nothing to do with how competent you are, how qualified you are, etc., etc. I work as an agency nurse. Yeah, I'm, 40 years in since the day I trained, 37 if you count when I qualified. And I've got numerous certificates, numerous training in critical care, intensive care, management, teaching, A&E, suturing, lots and lots of things. Because when I trained, courses were plentiful and you could attend them and become qualified, and you were heavily assessed. You had to know your stuff, your theory, your practice. You had to be good because the system that we had in place then was very, very robust. I'm not saying it isn't now, but what I'm saying is we could do with going back to how we had it before. It was very safe before, I believe, more safe in my opinion than it is now, but that's a whole nother topic. Now, these nurses are working in different hospitals as agency, bank or permanent staff without having the qualification. Often they work together in pairs or compare and contrast and learn off other nurses when really they should have proper competency documents in place. They should be assessed by a nurse assessor who's gone through a period of training and has the experience to assess nurses in order for them to cannulate, take blood, give intravenous drugs, give intravenous medication, make up intravenous medication in drip bags or in a syringe pump, etc., etc. If a nurse says, I worked in intensive care, working in intensive care and being trained in intensive care are two different things. It takes a whole other skill set to care for a ventilated patient. Back when I did my EMB 100, which was a year-long course back then, and then it went to 9 months, then 6 months, and now it's changed again to a diploma in critical care. But we were so thoroughly trained. We had consultants asking us questions, testing us on x-rays, testing us on ventilation settings, senior nurses assessing our care, and we were not allowed to look after ventilated patients unless we had the competency, the skills, the theoretical knowledge, and applying that knowledge to the different patients that came in through the door. Otherwise, you couldn't say you were an intensive care trained nurse. It took 2 years on average, or it took longer than that because there was in-service training, to be able to take any patient with any condition through the doors of that ICU. That training has gone on today. I can still do it now, did it all through COVID. Those skills never leave you, and you have to have continuous professional development in order to stay on top of the latest changes and trends in critical care. Okay, the nurses who are bank, which means they work in a hospital, say full-time or part-time, and they do extra shifts as a bank nurse, slightly higher pay and on a very ad hoc when needed basis within their own hospital, so their contract is slightly different again, but that again doesn't reflect on their skills, their knowledge and their training. But all of those nurses should be checked by the NMC. They should check that their registration is what it says it is. that they've gone through that training, that they are who they say they are. Where did they do their training? What level was their training? And unfortunately, the NMC, it appears, hasn't done those due diligence checks. So there are some nurses suspended, many who've not been discovered as yet, who are working under somebody else's licence, which is really worrying. And if the NMC is bullying and part of a toxic culture, why is this happening? Nurses have already got a toxic culture to work under. It's an absolute disgrace that an NHS that cares about patients doesn't care about its staff. And let me just go on about this. One issue that's happening under a typical shift, and I'll go through what a typical shift entails in various guises, is the UK, the USA, Canada. I think Australia may be included in that, but I can't say for certain. Registered nurses are leaving in their droves. Now, that was unheard of in the UK. Once you trained to be a nurse, you normally stayed in the NHS for life. You worked in community or critical care or a ward or whatever, community clinic or heart failure, surgery, whatever. You went and you worked. You could work privately and keep your hand in by working in the NHS part-time. But you had to prove you are who you say you are. Today, yeah, I have to prove who I am, even though I'm born in this country, even though I have a passport in this country, even though I've been qualified for such a long time and I'm known to the NHS because I've worked in many roles. I'm still got to prove who I am. And yet there are people who have slipped through that net, and I can't get my head around how that's happened. Now, because of that, and because of the punitive effects of nurse regulation, whereby people can put on spurious allegations about you, where bullying is rife in the NHS, where mobbing, which is groups of people who can attack your character, can cause your life to be a living hell in an already stressful position, where you have to be right about your medications, where you have to work long shifts, conflicting shifts, so night shifts, earlies, lates, overlaps, long days. I mean, most of these shifts are 12 hours. Very occasionally you'll get a smaller shift, say 6 till midnight or some combination, but that is rare. It's mainly 12-hour shifts, and they're not 12 hours, they're often 13 hours or even 14 hours by the time you've actually got out through the door. Now, an hour of that is unpaid. Breaks, unpaid breaks, used to be paid. So 2 half hours or 4 15-minute breaks, however you want to take it. And in that half an hour, you've got to find a microwave that's normally shared with about 10 other people who are also taking their break or need to eat. That includes doctors. And this is mainly A&E. It can be the wards as well. Look, a bit easier on the wards. Not easier, but a little bit easier than A&E. You have a place where you can get a cup of tea. Often there's no hot water, the boiler's broken, there's no kettle. If there's a microwave, it may be working, but you're sharing it with many others who are also wanting to heat up their food at the same time. Toilet, fit that in as well. So you've got to go to the toilet in your break. Some hospitals are more easygoing about that than others. Others time you, others watch you. You have staff, sisters, matrons who will write down when you go for your break like you're some naughty kid and time you that you've only taken 30 minutes. I mean, it's what a way to treat adults, professional adults, but it does go on. Toilet times, that will often be noted as well. What, going to the toilet again? I've heard it said to nurses. The stress, the absolute stress of having too many patients. Now, in some hospitals, an RGN is allocated 4. In A&E, you're allocated 4 patients. In some, it's 6. Now, what that doesn't take into account is something called acuity. And acuity means how sick that patient is. So if you get, say, a cubicle of 4 patients. That doesn't sound very much, and they're all young people who are up and mobile and walking, probably got some abdominal pain or chest pain, and they feel a bit breathless and anxious, or they might have a mental health problem, or they're feeling unwell, but they're otherwise up and about. They can toilet themselves, they can move with a bit of help, you know, even if they're doubled up in pain. They're relatively independent. Different scenario. You can get your documentation done, you can get your medications done, you can assess your patient, you can treat their pain and type up your notes. It's not impossible. You'll be asked to do other things in that time, but it's manageable. And I'll come to this when I talk about the structure of a shift. If you get 4 old people who've, say, fallen onto a carpet and the care home is just being diligent and they want the patient admitting and seen by a doctor, patient could be on anticoagulants, they might have hit their head, it was an unwitnessed fall, and that person's got Parkinson's disease and is very elderly. Those patients with mobility problems, incontinence, etc., have to be assessed. They have to have their skin looked at for any sores or breakdowns or problems. They've usually got a pad in place which could be soaking with urine, so you have to wash them and make them comfortable and maintain their dignity. They could have a chest infection, so they coughing all the time and get breathless, so you have to give them nebulizers and medications to breathe in. That takes up a lot of time when there's one RGN, and that's just one patient. You get 4 of those, or someone who is very unwell, and you're going to struggle. You really are stressed and struggling, because getting the medication, organising your patients, going with them to x-ray because they need a nurse escort because of a drug they've got in their veins, etc., all takes its toll, and it's busy. So you don't even get a chance to get a drink or to go to the toilet. So you usually have a bladder the size of Blackpool, and you're normally dying of thirst. Now, one of the tenets in the NHS is your patient hydrated? So either they're offered and given drinks and or intravenous fluids, a drip. But our staff, maybe I should have a drip and walk around with it in my vein, and that way I'll get hydrated instead of, you know, taking time to drink. You're not allowed to have a drink in a clinical area. So if you're at a desk, you used to be able to have a cup of coffee, cup of tea, soft drink, water, whatever, and type up your notes. That was banned by the CQC because it was seen as unhygienic and unprofessional. There are no words. Of all the problems in a hospital, drinking at the workstation is not one of them. So as a result, you have to go off to drink. There's either a drink station, like a plastic box where you put your bottle. I mean, it's unbelievable, the indignity of what nurses have to put up with. Now, a typical shift, and this is where this will all make sense. In A&E, you can have 2 different shift patterns. So 7:30 in the morning till 8 at night, 7:30 at night till 8 in the morning, and that sort of half an hour overlap allows for what's called handover. So you arrive on duty. I used to get there half an hour, 15 minutes before, have a cup of tea, go to the loo because I knew it'd be a long time till I go again, usually morning, hang up my bag, put my lunch in the fridge, chat to my colleagues, and then we go to a handover room. We get to know what's happening in the whole department, how many patients there are, how many are mental health, how many are waiting to go to the ward, etc, etc, etc. Any housekeeping issues, you know, there's no scanner for the bladder, there's no drugs, you've got to go to the ward to get X drug, whatever. You get housekeeping details. Then as a nurse, according to your experience and knowledge, you're allocated an area. So I used to be in resus a lot, or majors, red majors it was called during COVID, but mainly resus, and I would be in there and there would be 4-5 patients allocated to me. I'd have another registered nurse with me, someone who was more junior, someone who was equal, someone more senior, whatever, and we worked together as a team. We had to do that and work it out between us because you have to keep an eye on all the patients, not just yours. So if I get the 6 patients and I'm allocated 3 and my colleague is, it depends on the severity of that patient's illness. I might take 5 because she's got a cardiac arrest in the corner bay, so her time is taken up with that. So it's all very fluid, and often I'll ask for help from a healthcare assistant. There are some patients who can have a healthcare assistant with them going for a scan, but if they're intubated or severely ill, it has to be an RGN. So you're spinning plates the whole time. I go in and check my area, check the oxygen, check the suction, check the drugs, check the emergency drugs, check the emergency packs, that we've got, you know, a childbirth pack, drug pack for major hemorrhage, trauma, blah, 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 all the equipment, ventilators, portable vents rather, enough drugs in the cupboard to access, because Resus has its own drugs. You don't have to go to a separate cupboard or pharmacy cupboard, and make sure that the area I'm working in is safe. I then get a handover from my day colleagues if I'm on nights, and vice versa. So we hand over about the patients, any treatments outstanding, any scans outstanding, extra x-rays, family, if somebody's died, sadly, you know, where the body is, the family are coming in to view the body, etc, etc. So you're dealing with all these things, okay? On top of that, you've got queries. So you've got A&E doctors coming in asking different things of different patients. So you're supposed to know, which we do. If you're thorough, old school, you know your patients inside out. And you take the time to do that because that's important. You'll then have speciality doctors. So doctors who will come down from the ward or from theatre, surgeons, ear, nose and throat doctors, neurosurgeons for the brain, orthopaedic surgeons for bones, etc, etc. And they want to know all about the patient as well. They'll have had a handover from the A&E doctor, and depending on how severe the patient's wounds are and condition is, that A&E doctor may be with the speciality doctor, and you've got to keep an ear out so you know what the plan is, what is happening to the patient. Are they going straight to theatre? Does the ward know this patient's on the way? We have to keep a bed for them, so that means that bed is taken, they can't admit from anywhere else, etc, etc, etc. You're spinning plates again. And that just doesn't happen once, that happens for every patient in there. So if I've got 5 and my poor colleague is with the cardiac arrest in the corner, I'm doing that for them all. Plus I'm keeping an ear out if the phone goes, because there's always a red phone, and the paramedical service will ring that phone and say, we've got a patient who needs resus, she's 65, she's had a heart attack, we've seen this on the ECG, her blood pressure's low, blah, blah, blah. I've then got to choose out of that 5 who I can move immediately. So not only do I have to pack up that patient with my healthcare assistant, all their belongings, any issues, any handbags, and yeah, all the things that people bring in. I've then got to hand over that patient to the cubicle nurse, the ward nurse, whoever is taking that patient. I have to go through the medications. I have to go through what treatments are outstanding, any allergies, blah, blah, blah. I've then got to come back, and usually I've got 5 minutes or 10 minutes to do this, get a trolley into resus for the patient that's coming in from the ambulance, check the suction and the oxygen because that may need changing if it's been used on the prior patient. Someone's got to clean that down. So the cleaners and the health cares and everybody else will prep that area. I've got to reset the monitor for the heart rate, the blood pressure, the ECG, etc, etc, and make sure the old data has gone, and get all my drugs ready, get ready, you know, the cardiologist, ECG, blah, blah, blah. Set up a trolley. Got to have a trolley for a cannula. If the ambulance has got one in, brilliant, I can use that. If they haven't managed to, because they're in a moving ambulance, and this takes some skill, paramedics, I hold my hands up to you, you're amazing. Big shout out to them. If they haven't got a line in, I've got to put one in. If I can't get it in, someone else will. Old school, I can normally do it 9 times out of 10. And then I've got to do blood tests and what's called a VBG. So you have a little syringe and that goes into a very quick sort of machine that measures all the body blood chemicals and hemoglobin and gives us a quick snapshot of what's going on with that patient at that time, whilst we're waiting for the blood bottles that are bloods are taken specific to the condition of the patient, and any previous medical history, that all goes off to the lab. So I'm organising all this, ready to take this patient. My paramedical colleagues come in. I'm getting blinking breathless just thinking about this. My colleagues come in with said patient and they give me a handover. They'll tell me what happened, the history, the patient's medical history. They'll bring medications in. They'll tell me all about Mrs. Smith, what's happened with her, that her daughter's in the waiting room or booking her in at reception, etc, etc, etc. And usually, especially older patients, they've got about 15 layers of clothing on, bless, and need all that to come off, because we need access to their chest to put a monitor on, to do an ECG, to get a cannula in their arm. If they're elderly and they've got dementia or mental health issues, it makes that 100 times harder. And you really have to get your skills together. If that patient has, say, got low blood pressure and is critical, they've got to have a urinary catheter as well. So we've got to measure the kidney function by measuring their urine output, as well as we're getting phone calls, x-ray are ready for you, patient needs to go to scan. Patient 3 needs to go to scan as well, and you've got all this going on. Speciality doctors come in for number 2 patient, because I've got 5, remember, and constantly you are dealing with 5 different things. And then someone will ask a question. Deb, you know the amoxicillin, blah, blah, blah. What are the side effects of that? Because my patient's now got a rash. It's never ending. Does anyone know the extension number for CT scan? Does anyone know where I can find the bladder scanner? Does anybody know where I can get some spare amoxicillin? It's relentless, and you have to have a very clear mind and a very cool demeanour to deal with all that stress because you are literally bombarded. That's the nature of A&E. It's a busy place. There's lots going on. I love the work. I love looking after the patients. It's just the politics I can't stand, because more often than not, you haven't got enough equipment to treat the patient. Not enough drip stands, not enough syringe pumps, not enough anything. Run out of drugs, whatever. It's a constant in A&E, and you have to send someone to the ward, but there isn't anyone because we're short-staffed, because we've got a mental health room and there's a patient keeps absconding, going off, or needs someone to go with them for a cigarette so they don't run away because they're a danger to themselves. There's somebody with dementia who's had a fall and has got a cut on their head, and they keep wandering out the cubicle, so they need someone to sit with them, and there's never enough staff. Then you'll hear an alarm go off. Patients collapsed in the reception area. You know, there's always something going on in A&E. It's hard work. The ward is very similar. They'll have their emergencies, but it's a little bit more toned down. Their issues are very different. They're busy in a different way. But for me, I mainly work in A&E and intensive care. And believe me, in intensive care, you're one-to-one, but you've got a lot of things to deal with one patient that I'll go into another time. So by now, you've come on duty and it's 8 o'clock, right? Because you've had your handover, because you arrived at 7:30. You look at the clock and it's like midnight, and you're wondering why you feel dizzy and a bit sick, because you've not had a drink, you've not had anything to eat, and your bladder's here, so you're desperate for a wee. Is there anybody around to keep an eye on my patients? I've got to go to the toilet. And this lady who's just come in with the heart attack, her daughter's in the waiting room. Can you ask her to come in? When I come back from the toilet, I'll explain everything to her. Daughter's upset, anxious, then starts having a go at the nurse who's looking after my patient while I run to the loo. And there's another issue to deal with. So if I manage to get to the loo, which is often rare because there's never anybody around, I'm holding on to the wee, and the pain is now getting insufferable. My abdomen's bloated and I'm starving. I carry on doing whatever. Patient, one of them goes to the ward, the lady with the heart pain goes to the coronary care unit, and the phone goes again. We've got another patient coming in. You've got to prep that area, get the drugs out, get a cannula out, get the blood bottles out, get the ECG machine. And because the ECG machine, there's only one that works, two if you're lucky, someone's got to go looking for that in the whole department. Yeah, in the whole department of an A&E, there's only ever one or two machines working that have got all the components and it's been plugged in and it's raring to go, because often they're not plugged in because people are so busy. So the battery drains and it takes ages to fix. Or you come to use the ECG machine because it's functioning, but the paper's run out. Where do we keep the paper? Oh, I don't know. Someone moved it the other day. So you've got no paper to do an ECG trace. And loading it up is a nightmare in itself, because different companies have different styles of paper that goes through the machine in different ways. And it's very important to have the correct calibration to read an ECG. So you don't get that right, and that ECG can be read completely wrongly and a wrong diagnosis could be made. So that has to be correct. So you look at the clock again. It's now 1:30. Anybody want to go for break? You ask your colleagues. No, I'm busy over here. And this is how it is. Nobody's got time to go for break. By this time, we're ravenous. You carry on sorting your patient out. Another emergency comes in. It's now 3 a.m. Yeah, 3 a.m. Dying of thirst. Managed to get a little cup of water. I've down quick. Bladder's still up here because I haven't had time to go to the toilet. Somebody's asked to get some morphine out because I've got the controlled drug keys. So I'm checking the morphine with them, signing it out. Nurse goes to give it. I seal up the cupboard. I'll go to the toilet now. Oh, Deb, by the way, have you got any whatever drug? We've run out because the cupboard that's in A&E hasn't got whatever the nurse is looking for. So they have to take the stuff out of resource. Does anyone know the calculation for this drug, that drug? Does anyone know where? Has anybody got a manual blood pressure set? Because my patient's blood pressure's so low, we might need to bring her to resus. It's constant. It's on the go. The next thing you look at the clock, it's now 4:10. It's like, I've got to have something to eat or I'm going to pass out. Can anybody just keep an eye for 5 minutes? I'll run. Go to the loo as quick as I can, wash my hands, go to the staff room, get a sandwich out or whatever, stuff it in my face, and I'm literally eating it in my mouth as I'm walking back to my work. There are lots of times when I've not been able to eat. There's lots of times when many of us, doctors as well, are not able to eat. Add in the fact, if there's some chocolate or there's biscuits or whatever, we'll just pick them up, eat them and go on our way, because it's easier, because we can type up our notes, we can deal with patients, whatever. Next thing, the speciality doctor comes in and says, all those medications that have been given by the A&E doctor, I want to change this. So take that one down. I want to give this drug instead. So you've now got to go and find whatever drug the speciality doctor wants and make it up as per prescription. Yeah, this is how it is. It never stops. There's also a checklist where everything has to be checked in the department every 24 hours or at least every shift. I normally go round and do a quick overview anyway. That's just how I am, old school. I like to know everything's working and present and correct before I start duty, rather than wait until I need it and then it doesn't function or whatever. But that's me. The next thing you know, it's 6 a.m. You've still not had your break. I've just had a mouthful of biscuit, one wee and 1 cup of water. I think it's not worth it now. I finish in 2 hours. I might as well carry on typing up my notes. Deb, you forgot to send this to the ward. Oh gosh, right, okay. Is there anybody who can take it? Is there a porter? Is there a healthcare assistant? No, you'll have to do it. So when my patient number 4 goes to X ward, we put all our bits and bobs belonging to another patient on the bed, and I can drop it off at ward X on my way past. That's the norm. Yeah, that's the norm. You're looking at the clock. Thank God it's 7:30. morning or night. The night shift are coming on, the day shift are coming on. You can breathe, yeah? So your day shift come on, there's another emergency coming in through the door and they've arrested. So everybody's dealing with the cardiac arrest because there's a lot of us around because the shifts are overlapping. I then managed to hand over, say that I couldn't check everything overnight. I gave it a quick glance when I came on duty. You need to order this drug, that drug, the other drug. There's not enough saline bags for the drips. We're running low. Can somebody order it? We've only got 4 vials of morphine. You need some more. I've, got a book and ordered for 20. You might need to add more to that. All these kind of ongoing issues, The oxygen on the wall is a bit iffy. I can't get it to flow properly. There's something wrong with the meter. Can somebody come and have a look at it? You've got all these issues all of the time, yeah? Plus heavy trolleys, heavy patients that need the toilet, that need a catheter, that need to defecate, that need care, yeah? As well as all the complex care that goes on. And it's relentless. So by 8 o'clock, I've handed over. Day staff are looking after the patients now. I've got notes to write up because I haven't been able to type them. I've not had the time. So I've jotted down on some paper that I've done this or I've given that or whatever, and I check all my charts that everything's been given timely, right amount and correctly, so that when the patient leaves A&E, everything's clear, what's been given, who's given it and why. So I sit down and I type up my notes on my patients. Yeah, if I've managed to do a little bit as the shift's gone on, great. More often than not, it tends to be everything at the end. And because of how my brain works, I store all that information in my head. So I tend to jot down everything that's done in an A, B, C, D, E format, and then anything else in a summary at the bottom. And my notes are quite comprehensive, old school. So by the time I finish that, it's probably about 20 to 9 in the morning. So I say goodbye to everyone, make sure all the keys that I've had hold of for the controlled drugs have been handed over, and I haven't gone home with them because that's something that we do regularly because we're tired. And if it's your second, third, fourth, fifth shift, you're normally dog tired. And I mean dog tired. Your brain is just numb. So you walk out, go to the loo, yeah, massive bladder goes down, go into the car and breathe. It's like, right, my brain is now numb. Drive home, have a shower, make a cup of tea and just eek all over. It's like, okay, fall asleep, get up and it's all done again. On top of that, for mums, there's kids, housework, meals to cook, blah, blah, blah. That happens 4 or 5 nights. At the end of shift, for those nurses who are in a full-time role with the trust, a substantive post, they can be finishing at 8 a.m. on a Friday, yeah, sleep, and then be back on duty 7:30 in the morning on the Saturday. Yeah. And then there'll be days, say Saturday, Sunday, off Monday, back in on days or nights, maybe a swap around. And then when it comes to annual leave, so you can go on holiday with your family, very difficult. You've got to put in all your requests in advance. They're often not given because there's only so many staff. There isn't enough leave so that the department is covered with enough skill mix and enough registered nurses. It's just hard going. And if you want 3 weeks off to go to your friend's wedding in the Caribbean, no chance. Special requests only. You have to put that in writing like months in advance, and it's granted by the matron if you're allowed to take 3 weeks. Sometimes it's granted, more often than not it isn't. So even I'm exhausted just saying that. That is a typical shift for an A&E nurse. Wards will be slightly different, community will be different again, midwifery very similar. It's a very fast-paced environment, and you haven't just got one patient, you've got 2. You've got mum and baby, or mum and babies if there's more than 2, 3 or 4. And it's hard work. It's very, very, very punitive. It's stressful, it's tiring, and it's not right. Oxidative stress, no fluids, lack of food, lack of time. I mean, staff rooms are not the most comfortable of places. You're very lucky if you get a good staff room in A&E. It's normally a load of very uncomfortable chairs, mess everywhere, coats everywhere, bags everywhere, because trusts don't look after their staff by and large. Although I will give a shout out to one hospital that I was really, really impressed by. It's the best A&E I've worked in terms of staff care. Royal Bolton Hospital in Farnsworth. Wow. Wow, that's all I can say. Big shout out to them. Their matron has got it right. Beautiful staff room, everything in it you could want. Nice table to eat from, relaxing chairs, enough breaks. They care about their staff in Royal Bolton. Excellent. If every trust learned from the Royal Bolton, it would be a lot nicer place to work and have your breaks in. So yeah, big clap out to Royal Bolton. You're amazing. I loved working there. I'd go again in a heartbeat if I lived near there, but I don't. I live miles away now. So yeah, so there is my rendition. I meant to keep this video short, but I haven't. It's now 40 minutes long, of what a nurse's day or shift is like. And you imagine that, as well as a house and a family and bills and extra shifts because you've got things to pay for. At least at one time you could have a holiday on your salary, and extra shifts were for extra money for special things. Now extra shifts and agency shifts are for essentials, which is a crying shame. It's just awful. So nurses are leaving in their droves because they've had enough. They've had enough. Add in a toxic culture and horrible managers and a punitive system, and it's a recipe for disaster. And it is a shame, an absolute shame, because the NHS used to be fab to work for at one time. Okay, I'll leave it there. I will be on my next video, which will be about the private sector, and I'll look forward to discussing that one with you. Okay, thank you for listening. Please like and subscribe. It makes a big deal to the algorithm, and YouTube like us content creators to mention it to you all. Have a look at the community as well. Please leave your thoughts. I love reading your comments and your thoughts. It's great to have that debate, and all comments are welcome. It's an open forum. I might not agree with them all, but I agree with your freedom to say them, put them. Okay, take care everyone. Bye.